To session 3, day 1, which is this effective and equitable engagement with the voluntary and community sector, volunteers and communities. I'm Jane Hartley. I work in the voluntary sector and have done for many, many years, but I'm also the regional lead for the Thriving Communities programme run by NASP, and I'm also the regional social prescribing facilitator for the North East and North Cumbria, working with NHS England. And Kerrie, do you want to just quickly say who you are?
Yep, hi, so I'm Kerrie Fletcher, I'm from Community Action Derby, and like Jane, well, we host the regional lead for NASP Thriving Communities for the Midlands.
Okay, so Kerrie and I are going to kind of do a double act co-chairing today. And as I was saying earlier, if you could keep yourselves on mute, if you could put questions in the chat as we go, and then Kerrie is going to kind of field those questions, and we may be able to actually take some questions live from participants. We'll see how we go. We were going to have 3 speakers, but unfortunately Alison McGregor from Altogether Better has had to pull out at the last minute due to some issues. So but we're left with 2 fantastic speakers. We have in a while Warren Escadale, who is Chief Exec of Voluntary Sector Northwest, and our first speaker is going to be Alex Boys, who is Deputy Chief Exec at NAVCA. And I think Alex is going to talk very much about what the voluntary and community sector brings to the health and wellbeing agenda, and then Warren is going to drill down a bit on how we may fit into and how you might work with the voluntary sector in terms of that social prescribing pathway. So without further ado, I'll hand over to Alex.
Thanks, Jane. Afternoon, everybody, and thanks for inviting me to speak today. Really excited to be here. I'm going to, first of all, because I'm never sure who the audience is that I'm speaking to, and I can only see mainly people's initials. I'm trying to work out where people are from, and I'll try to adapt what I'm going to say to that. So if you could just put in the chat right now what type of organisation what sector you're from. So if you're from the voluntary community social enterprise sector, you just put VCSE in the chat. So if you're from the kind of statutory public sector, if you just put pub in the chat, and if you're from something else, just put other or what it is. That would be really helpful for me to kind of gauge who I'm talking to. I'm hoping you can actually access the chat now. I've said that. I assume you can. Oh, okay, good. Fab starting to come through. That's good. So far, mix of public sector and VCSE. Okay, yeah, primary care, great. Okay, so as Jane's just mentioned, my name's Alex Boys. I'm Deputy Chief Exec of an organisation called NAVCA, which, if you're not aware of us, is the National Association for Voluntary and Community Action, with a membership body for local voluntary sector infrastructure organisations that operate in England. And at the last count, because it changes upwards quite frequently, we have 189 members operating across England. And I'm pleased to say that Jane, Kerrie and Warren, who's speaking next, are all within NAVCA member organisations. My role in the organisation is currently leading on our work to support the voluntary sector, embedding into the establishing integrated care systems, and also to support some work doing around social prescribing. And in a previous role, I led an infrastructure organisation myself, where we delivered a social prescribing programme in the Midlands, as you may be able to tell from my accent. And we worked alongside 5 primary care networks, the local public health team, and local adult social care teams to deliver that service and reach many thousands of people to support them through the project. So I'm going to start sharing my screen now, I hope, and get some slides up. And as I said, I'm going to try and talk a little bit more about the kind of more widely, what's the role or roles the voluntary sector plays in integrated care and healthcare systems more generally, and then try to bring it back to social prescribing as a segue into Warren's section on the principles that he's developed. So as I've said, NAVCA supports local infrastructure organisations. I'll briefly describe what they do in case you're not aware. That map there on the left-hand side of the slides is an indication of where our members are based. You'll see a really good spread across England. And they have 4 main functions that local infrastructure organisations deliver. So in terms of leadership and advocacy, they're there to listen to the broad and varied range of community and voluntary organisations that operate within their area and understanding their needs and aspirations. And then from that to advocate for them with a whole range of stakeholders. So local authorities, health services, funders, national organisations, and other stakeholders that are interested in working with the voluntary and community sector, or should be interested in working with the voluntary and community sector. Local infrastructure organisations also support partnerships and collaborations, both within the sector, supporting the collaboration between local voluntary organisations for service delivery or to affect change, and also to build those relationships with statutory public services as well. And we saw some of that really very obviously through the pandemic, where we saw great collaborations being developed through the work of local infrastructure organisations to support communities with the issues that were arising through COVID. They are also critical in community development and practical support. A big area of local infrastructure organisations' role is to support the development of the voluntary sector, and that can take a whole range of practical approaches, from working directly with communities and supporting community development to create new voluntary action, community action, help them to establish new groups, help them to make those groups more formal if they wish to register as charities, and to support the existing voluntary organisations as well to establish, develop, sustain their services. And that's through practical advice around governance structures, around business planning, and of course securing funding and making sure that funding is delivered well too. And then finally, members and local infrastructure organisations have a key role in supporting and championing volunteering. So that's about helping to share best practice in volunteering. It's about looking at ways to identify and dismantle some of the systemic barriers that may be in a place and preventing people from participating in volunteering, and helping connect individuals to volunteering activities. So many of their members also run volunteer centres where they will actually do that brokerage of opportunities and individuals interested in volunteering. So that's broadly what our members and local infrastructure organisations do. But just to focus that down on health and care then, they are very much involved in the new integrated care systems being established in England, and they're providing several roles in that. They're providing voice and representation, as we just talked about, and engaging the ICS in conversations around that. They're providing that voice and representation both for the sector, in terms of the voluntary sector as a group of organisations, but also supporting the voice of people and communities by virtue of the organisations that they support being drawn from the communities that they serve. They are supporting what we've called system stewardship, and that's helping to make sure that systems, as they develop, retain that focus on addressing inequalities and putting people at the centre of the thinking, and don't stray too far away from that. And they are playing an important role in coordinating the sector through the systems as well. As I mentioned, COVID was a really clear example of where that activity took place. And then finally, they're providing a high level of data and intelligence to the systems as well, which helps to inform the priorities that the systems might want to take up in the future. And it's fair to say that I think all of our members would say that health is both their biggest one of their biggest focus, biggest opportunities and biggest challenges at the moment. So to talk briefly then about the wider voluntary sector and their roles in health and care, and I've put right at the top of that that slide, if you can see there, a quote that's come directly.
Alex, I don't know if it's just me, but your slide has disappeared.
No.
Is it for everybody?
It looks like Sue's accidentally shared a screen over the top of yours, which is blank. So if you just want to reshare again, it should be okay.
Oh, now I can see myself. It's even worse. Let's try again. Is that back?
Yeah, it's back. But if you could put it on presentation format, that'd be brilliant.
There we go.
Great. That's it. We're back.
Fab. Okay, so I started off there with a quote direct from NHS England, which I quote at all times, which is in their latest guidance, and states that the voluntary sector, voluntary community and social enterprise sector is a vital cornerstone of progressive health and care systems. And I think that's incredibly clear. And I would absolutely stand by that statement that without the voluntary sector involved, it will be missing a really fundamental part. But I think sometimes we can often overlook all of the roles that the voluntary sector plays. So I'm kind of focusing on the different roles, and I think it's often overlooked what we mean by the voluntary sector sometimes as well. And so when we talk about the voluntary sector, we talk about a very broad body of organisations, and that includes registered charities, both small charities, larger ones, local charities and national ones. It includes the local volunteer-led community groups that are maybe more informal and led by a group of residents. It includes sports groups. It includes faith organisations delivering a community activity. It includes cooperatives and mutuals, mutual benefit societies, and of course social enterprises as well. And even within all of those different types of organisation, there are still things that fall between those categories. And so it's all that civic activity that we're talking about when we talk about the voluntary sector. And I think we'd all agree that the voluntary community social enterprise sector has always supported health and supported health and care outcomes, and it's something that I think that the health and care systems have come to rely on. But I think we need to sort of think about what roles the sector plays and making sure that they all get equal thought as we engage them in integrated care. So I've identified 4 key ones on this slide, which I'm just going to outline a little bit more. So we've talked about the sector as an opportunity to bring community voice and engagement into the system. So that bottom right-hand corner there. And the reason why I think it's absolutely critical that we think about the sector in this role is because they provide a level of opportunity for engagement that others might not. But by and large, the sector is drawn from the communities that they're supporting, which means that they have a very deep understanding of local needs. And they also often have early sight of emerging issues in communities. So they can see what's coming up and they can help to inform health and care colleagues about the challenges that are being faced, whether that's about access to services or whether it's about how messages are landing and how things are being identified. And similar to that, the voluntary community sector have really strong relationships of trust with communities. They're not seen as an outsider often, they're very much seen as part of that community too. And then finally, on that aspect of their role, they are based on lived experience and have connections with those communities that are not traditionally reached or sometimes not reached. So they can provide a level of insight and ability to connect with communities that statutory service in particular may find more challenging to talk with and work with. In the top right-hand corner there, talked about the sector's roles in terms of collaborations and partnerships. And this is about how the sector has an opportunity to bring a wide variety of organisations into the fold, and actually, to be quite mercenary about it, to attract wider investment into an area. Often volunteers in community sector organisations have the opportunity to attract funding from sources that statutory partners might not, and also opportunities to work in ways that are more innovative through those funding pots and opportunities that exist there as well. And finally, on this one, I'd say a key way in which the voluntary sector works in terms of partnerships is to find ways to bring capacity building into that. So partnerships that are developed in the voluntary sector tend to factor in a level of capacity building within their partnerships. So new opportunities and new organisations develop as part of those partnerships too. And then onto the left-hand side of that block, the top left-hand one, I think, is the one that's most broadly and commonly seen as the voluntary sector's role, which is providing support and service delivery within an area, and they absolutely do that. The voluntary sector is a really critical provider body in any health system that provides levels of support, whether formal or informal, and they do that in a way that's flexible and dynamic. is often innovative, and I think what's really important is holistic and person-centred and preventative by default. And it's really great to see the focus on prevention that we're seeing now, and early intervention. And I think it's fair to say that that's always been the voluntary sector's way. Rather than looking to treat an individual issue within a community or an individual, it's looking at the whole person. And of course, as we know, that's what social prescribing is all about. And then finally, on the bottom left-hand side, we talked about the voluntary sector's role in terms of providing knowledge and insight. And I think this is an area that's probably most underdeveloped in terms of how the voluntary sector works within health systems. The sector holds a huge amount of information about communities, as I said earlier, about the deep understanding of needs. And that's often overlooked. Often when voluntary sector organisations are engaged in health, they're engaged through a service commission model where they will be asked to provide data and intelligence, mainly data, to describe how that service has been delivered and whether it's been successful. But very rarely is the sector asked to inform on the priorities, whether it's commissioning priorities or wider priorities that a health system should be looking at. And I think that's a big oversight at the moment, and something that we could look to work more with voluntary sector organisations to support health systems. And thinking particularly around social prescribing, there's a really good base of knowledge and information there to understand how the needs of the voluntary sector, so the needs of people who are supported through social prescribing, is being plugged back into the prioritisation in health systems. Jane, I'm aware you said we might be asking for questions anywhere through this, so feel free to stop me if you want to ask anything. I can't see the chat box, so if there's anything that's come up, then I'm happy to.
There's nothing in it at the moment, but I don't know if anyone wants to quickly highlight something with Alex before he moves on. If you want to perhaps raise your hand if you do, or stick it in the chat.
Nothing at the moment, Alex, so I'd carry on.
Okay, so
All
carry.
right. I'm happy to crack on. I might say some things that are a bit more controversial now, which might cause people to raise their hand. So from that kind of overview of what we see as the key functions the voluntary sector plays in health systems, these are some of the things we've identified that I don't want to steal Warren's thunder in talking about principles. These are some of the key things we've identified are kind of critical to making sure that relationship works well. So the first one is pretty much well understood, I think, by all. It's about fostering relationships. And we want to make sure that relationships with the voluntary sector are invested in at all levels, whether that's, and I think often we can see that relationships are built well at strategic level and often at the coalface or at the direct delivery level, and then there's often a gap in the middle where there's less of an understanding and relationship. And it will only work where there's a really strong relationship of mutual trust and understanding between sectors. In England, obviously, we're going through some quite significant structural changes at the moment. The establishment of new integrated care systems with boards and partnerships that will work together and place governance. And I suppose I've seen the changes in health structures go around twice. And what I think we've identified is that the structures don't really make the difference. It's the relationships that do. So whatever the structure is, invest in those relationships with each other more than investing in the structures, because they won't actually change much. The next one is invest. Again, I'm sure you've heard this before, particularly for statutory colleagues on the call, but I think it's really important to repeat. Delivering requires resource, but actually involvement and engagement with the system requires resource. So funding services and activities is critically important, but there needs to be a recognition of the value of engaging the voluntary sector in that governance, the discussions, the decision making as a key and critical partner in the system. The next one is about being generous, and again I think this goes across sectors, being generous with knowledge, skills, expertise and connections, and I think it's recognising that we can all bring something to the table based on our experience, and we've seen some really good examples of where skill sharing activity between statutory and voluntary sector partners has helped to develop those relationships, as I mentioned in the first point. Also about being bold, and this is a really interesting one when thinking about the current structural changes in England now, and being bold about who leads what and where, and actually making space for the voluntary sector to lead on elements of health system delivery where it makes sense for them to do so, and making sure that strategies are focused on what really matters to people. So rather than a strategy that may be focused across a whole system area, which might be quite broad, maybe devolving that down into neighbourhoods or communities where it makes more sense to people, and voluntary sector organisations can really get involved in leading the delivery of those strategies as well. And then giving equal value to the insights and intelligence, and this is, as I've just mentioned in the key roles, the intelligence that the voluntary sector holds can often be overlooked as being secondary to that statutory partners and others holds as well, partly because it tends to be far more qualitative, and partly because I think there's a lack of understanding about the level of information that voluntary sector organisations can provide. We're seeing more of a move now in terms of greater qualitative information being included in strategy development. For example, joint strategic needs assessments, which are requirements in each local authority area in England, now have started to include more qualitative assessments. And I just want to kind of keep hammering home the point that the voluntary sector is an absolutely critical place to go and find that information direct from communities. Similar to the different roles in the sector as well, there's different types of organisations. I think it's really important that when working with the sector that you recognise those different types of organisations. It can be easy to lump the whole voluntary sector all together in one, but just like statutory partners, there are different parts of the system within the sector. There are infrastructure organisations like those that NAVCA supports. There are those that support community voice as a priority, such as Health Watch organisations, and there are those that are direct delivery organisations and other supports as well. And then staying connected is really important as well. It can often be tempting to engage with the voluntary sector at a point in time and identify the work that needs to be done and then move on. But the voluntary sector is an incredibly dynamic place. Things start up and stop as things go along. It's responsive to the needs of communities. So staying connected with the voluntary sector and that constant changing landscape will really help you to understand how to continue to work with the sector as it evolves. And then finally, on this slide, because I'd probably lose my job if I didn't say this, is that I'd encourage everybody to stay connected with, invest in and support local VCSE infrastructure bodies. They are often the eyes and ears of what's going on in the voluntary sector. They have deep-rooted connections with the wide range of voluntary organisations in your area. They tend to know what's going on and what the sector needs, and can amplify that voice and help you to understand that too. So I think I've got one more slide. No, I've got two more slides, sorry. So trying to bring this back then to social prescribing, I appreciate I've probably gone a bit off topic there already. In its simplest form, I guess social prescribing has got two key ingredients. It's got a referral mechanism, which is the link worker, and it's got the support or activity or service that they're referring to and to support the individual. But I think I don't think we'd all be here if we didn't know that it wasn't that simple. And I think to make it work smoothly, it's about looking at all the other things that need to go around that, and how do we support that kind of marketplace of activities and support the referral mechanism to work effectively. And it's a circular thing from our perspective. And a key area that we're working on now is about how do we develop that support and capacity building role within the ecosystem as well. How do we ensure that there's a feedback loop between the support that individuals get, the the people doing the referring, the organisations doing the referring, to make sure that supply and demand, if you like, continues to make sense to each other, and that there's enough support, resources and relationships built to keep that feedback loop going round. So I think for social prescribing to support people effectively, we want it to, and to ensure it remains sustainable, we need to maintain those strong relationships between the sector and statutory bodies, and we need to make sure they're based on mutual understanding and trust. And I think that's about understanding how each other operates, and also understanding the opportunities and constraints that we all work within. We need to ensure there's a sufficient flow of resources. I haven't been on the start of this call, but I imagine that's come up at least more than once in terms of how do we make sure that the resource follows the individual, and that the support that they are placed within, or activities that they're placed within, gets the resource it needs to continue to support people. And I think that follows then that needs to be based on a really full understanding of what's needed, informed by the data and intelligence that we can collect from social prescribing and from communities themselves. So I think that's the key ingredients for me. And then I suppose this is a bit of a cop-out, but I thought rather than come up with a load of answers, which I'm clearly unable to do, what I've come up with is a few questions that I don't know the answer to, but I think are worth exploring in more detail, whether in this space or just to think about in the future. And these are things that we've come up against time again in terms of working with our members and talking about social prescribing. So the first one that we've identified is that perhaps the strategic importance of social prescribing as a route to address inequalities may not have been accepted equally amongst all partners in a place. So we know that NHS and NHS has invested significantly and is really committed to social prescribing. It's not clear whether all of the other statutory partners, in particular local authorities, are seeing it in the same way. And in turn, that leads on to the second question about how effective has joint implementation planning for social prescribing been in places to date? And do we need to do more to support everybody in this space to work more effectively together to understand the outcomes it can achieve and the resources it needs to be successful? Next on from that, another question that comes up time and again for us is there a tendency to focus social prescribing as a service delivery model, i.e. people into support, rather than an opportunity to build community resilience? And this is a really fundamental one. In the social prescribing service that I ran a few years back, we talked about our gold standard being an individual referred into the service. The outcome for them was that they became a volunteer or active member of their community, not that they were placed in a service that supported a need. So for us, we always saw social prescribing as a means to building community resilience, which has a self-sustaining impact, rather than a means to getting a person into a service that might support an immediate need for a specific amount of time. The next question is about, is there sufficient focus on the benefits of investing in building community and VCSE capacity? And that's linked to that resource issue again. Are we really clear about how we are understanding the flow of resources to meet the needs of the sector who's been asked to address and work with social prescribing? And then also, is there a common approach to how local social prescribing insights, intelligence data is collected and used to inform these needs? And finally, I think it's probably been done to death, but there's no harm in keep repeating it. How are we identifying who should be responsible, and how do we join up historically separate roles for resourcing and supporting the voluntary sector, who the majority of the capacity requests comes down to when we're talking about social prescribing? So that's a set of questions that we're exploring. We don't have answers to, but I'm always keen to speak to anybody who might be interested in any of those questions. And I've just on the end there added a link to a recent report we did around the experience of our members and other local infrastructure organisations in delivering social prescribing, both in terms of hosting link workers, but also in terms of supporting the voluntary and community sector who are receiving referrals from social prescribing programmes. So that's it from me, Jane. I hope I met the brief as well as possible. I'm trying to stop sharing.
Well, actually, I was going to suggest you don't, because there's a lot of questions there and it's quite difficult to absorb them. But I actually think that they're pretty bang on, really, in terms of, especially in this kind of changing world where we're moving towards ICSs being statutory bodies, we're working towards primary care networks developing partnerships with the voluntary sector. And, you know, I think you come up with a really good list of challenges and this age-old question of who funds the voluntary sector. And I think it was interesting. I'd just like to say that listening to Merran Simpson speak from the Health Creation Alliance, she was pointing out that we've created these, NHS England has created these social prescribing link worker roles, and there's an expectation that part of their role will be about kind of community development and capacity building in order to meet some of the gaps in services and support. And, you know, is that realistic? Is it appropriate? There's something about skill set, there's something about capacity to do that. And actually, isn't the voluntary sector and voluntary sector infrastructure a much better place to do that? She was also talking about, since we've put social prescribing link workers within general practice, referrals to citizens' advice have gone up 600%. So you've just moved the problem, you know, and how do we deal with that? So clearly that big question about investment and about capacity building and infrastructure, there's no point in having lots of travel agents if there's no holidays at the end, you know, is kind of really really omnipresent, I think. So well, yeah, it's good to see people's faces, but I don't know if anyone wants to come back and ask some questions of Alex before we move on to Warren.
We've got one question in the chat. Sorry, Jane, we've got one question in the chat. Did you want to come back on that first, though, Alex?
Yes, thanks. I mean, two good points. I've just seen, actually, and I think I've just seen Christiana's question in the chat. I'm not sure, it might be worth asking her I'm not sure I understand it fully, but it's really interesting what you just said about the role of social prescribing and community development. And Christiana and I have never met, but we've had an exchange on Twitter, and this is the new connected world we live in. And we talked about exactly that. Is what is the role of link workers and social prescribing in terms of community development, and is the skill set there to do both? And I think, you know, it's about sharing the skill set amongst everybody operating in this space, so we've all got an understanding of what it takes. But I would always say that community development is in itself a role and not an add-on to another role. Having spent, you know, almost 2 decades now working in the voluntary sector community development field, you know, I recognise that it's a very, very specific skill set. It would worry me for a number of reasons if we decided that social prescribing link workers were also community development officers or community development workers, because they wouldn't have the time, they wouldn't get the support, because they'd be trying to do 2 roles, and I think it would lessen the impact. I think that social prescribing link workers working alongside a specific resource for community development and voluntary sector support is the best way to go, because it means that both of those critical roles get exactly the right amount of resource that they need. And I think there's a real risk that if we try to combine those things, then we risk not giving both the full support that they need.
Kerrie, did you want to flag anything that's come up in the chat?
Yeah, there was a question earlier on from Christiana about what do you think about the person being the commissioner of their social prescription. I don't know if you want to speak to that, Christiana, and just to say a little bit about what you meant.
Yeah, I can expand on that. Sorry, you can't see me just yet. So what I meant was there are some schemes that I see that working well, where when we say the money follows the person into the community, but then the person actually will choose from the many of options that's available, because it just seems we just get stuck with, oh, give us the money, you know, and then, you know, there are still gaps, you know, there's not really meeting people's needs and things like that. So if it's about empowering people, is that something that we should be pushing for, you know, where the person is the commissioner of their own social prescription? I know that there is a push towards personal budgets and things like that. Do we have any thoughts on that?
Do you want me to come back on that? Yeah, so I think, I mean, it's a good point about the person, the money following the person. I think way back when NHS England started talking about it, that was the ambition, as I understand it, and I think it's shifted from there. I think there's some value to thinking about how the money follows the person better, whether it's through direct personal budgets and it's an individual budget for somebody to go and commission that activity or service. It has some merit, but I think it's the bit about whether it's a service or an activity that we want the person to do, or whether it's connecting them into their community and making them part of a vibrant community is more important. So I think, yes, it could work, but I think there's always going to be a gap and a need to be supporting community activity in and of itself and separate to social prescribing. There's a risk if we see everything that's community development as social prescribing, it narrows the field for that kind of activity. So I see it as three, as a Venn diagram, if you like, with that link workers, social prescribing, the referral mechanism, and then the body of civil activity, however we want to call it over here. And then there's a big bit that we tend to miss off when we describe it, which is community support and development. And without that absolutely critical piece, these two things will not get what they need. So for me, that third circle is more important than saying, you know, the money needs to flow. How the money flows, it doesn't matter as long as it flows to all three parts, critical parts of the system.
And I think there was some research done by Richard Kimberley and the Social Prescribing Network that came up with that exact circle, saying you need those different components. You can't just have one of them for it to work. And I think there's a danger in us not waking up to the fact that you need that component until it's too late, you know, because we have seen a disinvestment in community development and infrastructure. And, you know, there have been particular challenges in areas which have not had the funding in terms of, and they've got greater health inequality. So you've got that going on as well. There's a comment in the chat about in Norfolk having a model of social prescribers based within advice charities, which works because it also invests in the services that will be in demand. So, you know, that's quite neat. But also, you know, we have we have social prescribing link workers hosted in the voluntary sector, which can often help support that agenda as well. And so that's an interesting model, but obviously there's a variety. I wonder if, I'm just looking at some of the other comments, but I wonder if we should now move on to Warren doing his presentation, and then we should have a bit of time at the end for questions to both speakers, if that's okay. Is that all right? Yeah.
Thanks, Jane. It's Warren Escadale from Voluntary Sector Northwest, and obviously that's the Northwest in England. I hope you're all enjoying today, and I'm sorry I missed Professor Marmot, but I have seen him speak a couple of times, and it's a really important part of all our conversations, especially in the Northwest. So there's a number of Marmot sites, so areas that are committed to tackling health inequality and the wider determinants, and three, you know, most of the Northwest has signed up to it, and there's a number of other parts across England, and then I think Singapore have as well. But they're picking up on developing their own Marmot health inequality strategies, and I think that plays a big part in some of the thinking behind the principles that I'll outline. I suppose what we're trying to do, we're trying to improve health outcomes for communities, some richer, some poorer. And we're also trying to build NHS capacity alongside that. But I think if we just do those two things, we won't make a sea change in the life expectancy or outcomes of individuals, where you can walk 1 mile within a community that's wealthy to a poorer community, and the life expectancy can be 13 years different, even in a modern Western country like the UK. So. And that doesn't begin to get into, living without disability as part of your life expectancy. So it's a huge part of what we're trying to do and what these principles are about. So how do we begin to get into something that can begin to address the wider determinants, as well as improving health outcomes and building NHS capacity? In terms of what's unique to the UK, I suppose the NHS is pretty unique, isn't it? And I think that's well recognised internationally. I think the other thing that's unique to UK is the level, despite the last 12 years of cuts and cuts and cuts, is the vibrancy of our voluntary sector. So I know I've met with academics from across the world who are interested in replicating our model in this country. So just give you a sense of numbers. Roughly, and this is very, very crude and it varies from community to community, but there's about 7 voluntary community, faith or social enterprise groups per 1,000 people. So in an area like the northwest of England, with a population of about 7.5 million, that means 50,000 groups are operating, some below the radar, as they say, so they won't be registered. Some will be properly registered charities or community interest companies. Some will be really informal networks of faith organisations, and some will be social enterprises where they're giving between 1% and 50% of their profit to their community or their beneficiaries as part of that process. So it's a really vibrant sector. So you've got to get a sense of there's a massive opportunity, which is what social prescribing in the UK is about, and how you make the most of that opportunity with the voluntary community faith and social enterprise sector in England. So that's kind of where we're trying to get to. A long time ago, I was trying to, one of the goals of what's going on in England is trying to integrate health and social care services. And a long time ago, I wrote an article that was about trying to develop something that was fully integrated. So how do you get councils, how do you get social care, how do you get health systems through primary care or acute services or community health? And then how do you integrate the VCSE sector fully alongside those systems? So I did describe it as a super lamb banana, which was one of it was supposed to be a lamb being genetically mixed with a banana, and it was part of the, believe it or not, it was called the Arts Transpennine Corridor of the north of England. It was way back in 1998, but it was about creating a corridor of art. And some may know, some may not know, but the super lamb banana is like a massive phenomenon in Liverpool. So the sculptures were done there by a New York artist, and you can still go to the cathedral shops or the Beatles Museum, and you can pick up your banana key rings. So the point I'm trying to make is there are ways to integrate things. Sometimes they don't want to be integrated, but there are ways and models to come up with to create things that can do more than just build the NHS capacity and look to do something that contributes towards improving health outcomes. So for me, social prescribing is part of, it's a means to an end. So it's part of trying to drive system changes that create the machinery to drive substantial long-term change for communities, especially for me in the Northwest, where 22 of my 39 used to be known as neighbourhood renewal fund areas. So with huge levels of deprivation, and it was a big part. So how do we create something that draws on the full capacity of the sector without exploiting it, but that creates a system that can change the future of our communities beyond just building NHS capacity and doing some good stuff just to reduce the number of patients going to see a GP on any one day. So these are the principles that we consulted with our networks and members across the Northwest. So I'll try and share. It's going to fall apart now, isn't it? So I'm worrying. And I've got you no pictures of a super lamb banana, but feel free to browse the internet now. Is that wise? Probably not.
We can't see.
It's me. I'm being an idiot, Jane. Sorry. Right, here we go. Come on, slides. Right, is it there?
No. Oh, there it is. It's there. Yes.
Oh, thank you, Jane.
And if you could share, if you could put it on presentation format, that would be brilliant.
I think it's lagging a little. I have now. Is it there now?
No. Yes.
Right, good.
Yes.
Right. So that's me. And we've given this a snappy title of SP9 for those who enjoy acronyms. And in terms of the background, developed in the Northwest, but in consultation with members and partners in the voluntary sector. So I know people are saying they're my principles, but really they were developed with VCSE leaders from across the Northwest. And that includes a key part of the programme of work, which was with our partners within the NAS Northwest Thriving Communities programme I've listed there. And much of it's based on some of the evidence that's been built up around the impact of Salford's Third Sector Grants programme and around being a good place-based grant giver. But you'll understand more about why that's included here if I go to the next slide. So you've seen all this. So what we've seen is that it's getting termed as all holiday agents and no holiday destination. So we've got a really substantial investment, relatively speaking, into link workers but no investment into anywhere that could support the take-up of referrals. So I've kind of got green to the left on the investment and red to the right. So that was kind of the key point that we're getting into. So when Jane's talking about that 600% increase in referrals to CABs, CABs have the most enviable data recording metric systems beyond any other voluntary sector organisations, I would suggest, in England. And so when they say that, they know that. Most of the rest of the sector will have an inkling, but they won't have that data. So I suspect that that is being replicated in a number of areas and a number of key organisations right across the voluntary sector in England, but they don't have the depth of data collection and traditions that the Citizens Advice Network does. So what we're getting to is a point where the sector is being referred to, used, but not integrated as part of a local model. So I've put here, so the devil of a good social prescribing model is in the principles. So these are the two main ones that we've got. So one was, let's create an open social prescribing system, one that's not just for general practice, but we can build in integration with other systems. So beginning to get into integration with referrals via benefit systems like the ones built in England by the Department for Work and Pensions, and then think through the referral mechanisms via other public sector agencies in a locality. So how could social care be part of this? How can we begin to address some of the massive challenges on more than just general practitioners? There are more than just those problems. They're just the peak of the iceberg that's going on in our communities at this point. And unfortunately, looks like it's going to worsen over the next year or so at the very least. So one, it's not, social prescribing is not just Christmas, it is for all. And how do we do that? Principle 2 is about making a nominal contribution to the sector's role through small local grant pots. So we've seen that if you invest in an immodestly substantial way in localities, you can begin to market shape and develop the sector's role in terms of driving the key needs of any community. So at the moment, we love helping, we love doing what we can, but we can only do so much on our own. And we need some of that kind of more strategic alignment support so that we are shooting in the same direction rather than duplicating each other. And we've seen the evidence through the Salford work around the use of small grant pots in terms of getting your sector geared up and aligned to tackling the real problems in an area. What we're not suggesting is the NHS pays for it all. I think whenever I suggest something like that, there's a feeling that the NHS can't pay for the entire voluntary sector. But what we're suggesting is a nominal contribution. So it's not much. What we were looking at was something like £1 per capita per annum. So across the UK, that would be about £65 million. And it took me about 17 goes to get the maths right on this, but I think that's somewhere equivalent to what have I put there? 1 penny for every £29 spent on the NHS. So the budget for the NHS for 21-22 was 190 billion. So just to put that in proportion, if you want to create a system that is going to make a difference, that nominal contribution is the way to go for me. So that was principle 2. Go to the next slide. It's going to go about 4 now, isn't it? A second. All right, principle 3. I only have the model in England, but it's host your link workers in a community organisation. I don't care who it is, but somebody embedded in a voluntary sector organisation in local communities. What you want to be doing is getting link workers who already have links. I've seen some areas where GPs have started up and they've spent 3 to 6 months with their new social prescribing link worker mapping out the local voluntary sector. There are organisations that know the local voluntary sector, already have the links, and more importantly, have relationships with those voluntary sector organisations that are more about a mutual network of support rather than trying to get somebody you've just met to do something for you for the first time without expecting anything in return, which is currently what the referral model expects. Principle 4, pay your community host organisations adequately. So it's a bit of an issue in the UK and England. So hosting should not be a loss leader. Voluntary sector organisations are getting into being hosts, and they know they're going to make a loss. That's even before you get into the possibility that your new worker may ask for basic rights like maternity leave or sick leave or anything else, and they are making a loss. So we are, as a sector, already contributing to the cost of delivering social prescribing, and the amount they get back currently, I think, is about £2,500. It might have increased slightly per link worker. So what we're suggesting is a very
it hasn't
still there, right? So what we're suggesting is that if you want those links through those organisations, they shouldn't be made to run it on a loss basis. So it's roughly 10k per link worker would be the recommendation. I don't think that's madness. Principle, I think that's a massive bargain, to be honest. So principle 5 is recognise the importance of a strong local voluntary community faith social enterprise sector ecosystem in legislation and guidance as part of a good local social prescribing system. So there should be principles in all public sector programmes that are cascaded down about building on community assets. Don't come into an area, build your new buildings and then expect the sector to want to get on board. You need to be building on local community assets, thinking through co-ownership models, cooperatives, etc., and asset transfers as much as possible if you need to do those. Definitely don't pretend you don't need to understand the local voluntary and community sector in order to do this. I think we've got to a model where we've got somebody hosted in GP practices sometimes, and there's a sense in which they're the ones that need to do all the partnership building, the relationship building, without anybody else from a GP practice or the local health system needing to do anything in order to develop their understanding of who they are asking things of. Sorry, it's really slow at clicking the next slide.
It's okay. You just have to absorb it.
Unless I've frozen. I've not frozen, I don't think.
No, you haven't frozen.
I've moved on. Good. Right. Social prescribing is not just for the NHS. So linked to principle 1 about an open and social prescribing system is principle 6. So support the local health and social care system by investing in social care link workers. So if we want an integrated world that the rest of our state needs and welfare system can build on, and that includes economic opportunities, jobs, training, then we need to include social care as part of this. This can't be something where, once again, we've got a two-state system in England working where we've got the NHS on one side and we've got all the other departments operating the other side, including local authorities. We need a genuine integrated model. So as a minimum, I would expect it to be connecting to social care. At the moment, there is some elements of this going on, but it's very much self-funded by councils, who once again are looking at hard cuts over the coming months. Very well, 1st of April. Principle 7, all government departments commit to build on local social prescribing systems. So we see a number of models, and it's really good to see lots of departments in certainly getting on board. So we've seen the Arts Council, we've seen DEFRA, and we've seen a few other departments looking to invest in social prescribing, so green prescribing, blue prescribing, and all sorts of other models. And what we're seeing is that they're running theirs almost in isolation. They're trying to connect them, but really what they should be doing is looking to integrate their models with that integrated local system and build from there. And I think we need to think through how work, pensions and benefits, business innovation and skills connect to these routes as well. What we're trying to address is health outcomes. And I'm hoping you've all fully bought on board to how health outcomes and wider determinants are interconnected and inextricable. So if you're just doing, how can I reduce the number of appointments a GP's got, we're not going to solve anything in the long run. As Jane said, you're just displacing the problem from one place to another. And if we can get this platform or this social prescribing ecosystem right, then we've got something that could really drive forward genuine change from a grassroots level. And so that needs to be enshrined at national level in their thinking. There's only two more. Principle 8, primary care networks. So these two are about building local care, not just siloing primary care. So supporting primary care networks, which are the coming together of local GP practices to think through how they can build on local VCSE ecosystems and not just draw on them without realising they are. And commit to that health neighbourhood model. So in England, it's 30 to 50,000 people population level. But thinking through how we can create something beyond a simple GP referral system. Principle 9 is allow for an additional potential sector allocation for each of the primary care reimbursement scheme roles. So there's substantial investment from the NHS going into GP practices to support them to address the pressures that they face, which is great, but that money could be much better spent if it begin to think through how you create that local integrated working model. So that integrated health neighbourhood that supports it all. Right, madly enough, I tried to do some estimates. I used to work, well, I won't go into that. But here's my cost estimate. So am I talking insanity is the key question here. And I think the ask of the NHS is about £109 million per year. So I went through the budget. So in terms of the principles, there's no additional cost around an open social prescribing system, but I think would be genuine cost savings to other actors in each of the neighbourhoods. Based on a population of England, and we were looking at the local grants, that's at 65 million. So it's evidenced and with some quality assurance costs built into that 65 million. I think we need some genuine academic evaluation of the benefits of VCSE host organisations, because at the moment it's happening by random actions rather than genuine intention at a national level. So a 100k piece of research should more than cover that, is my logic. An uplift for the link worker host, we probably should include an uplift cost given the cost of living as well alongside that, but I've not, which was developed last summer. Research into impact of an effective local VCSE infrastructure agency in a local integrated health and social care system. Again, about the same in terms of the research costs. I'm pushing personally for local infrastructure organisations to be connected in, not because they can by any means mimic or cut out the need for citizens' advice services, but because what we're trying to do is integrate the wider VCSE sector alongside CAs. So I saw some really good models. There was a really nice model early on that's run out of money in Bolton, where the Citizens Advice, Age UK, and a network of other specialist organisations were each connected into delivering the service. So they ran it at a council-wide level rather than breaking it down into primary care networks. And then they looked at different cohorts and networks of people across the borough rather than using we're going to do this in our little 30 to 50,000 health neighbourhood patch. So you could come up with a model of working with the VCSE sector that's far more dynamic if you could step back a little bit from the new health neighbourhood footprint and think through how you'd cross-reference that health neighbourhood footprint with the local authority level where it's of substantial size. Anyway, so I've put in there for the investment for social care. So technically speaking, that might not even be VCSE investment, but I think in terms of driving some integrated working, it needs to be asked. Number 7 and 8, there's no additional cost there. It's just about commitments and principles being held up. The first one at national level and the second one in the rollout of the new primary care network model. And then that last one was a host fee of 10k available for additional roles. So that adds on 20 million. So I don't think it's pie in the sky. I think it's a very reasonable offer and should be seen as something that can not only address health outcomes, build NHS capacity, but build the basic building block of how we could drive change across our communities in a far more substantial way. I've just put my contact details on the end of there, but I'll stop sharing there. Okay.
Thanks. That's brilliant. If you could go on mute, Warren, just briefly. That was fantastic and very much food for thought. And we will certainly be using those principles to take to our ICS in the Northeast and North Cumbria, because we've all got to push for this, otherwise it won't happen. And thank you for doing all those calculations that just do my head in, but very useful. Okay, so there was something like Christiana was asking about, you know, how do we, is there any work going on about communicating the impact and value of the voluntary sector better? I mean, to be fair, there's lots of us been trying to do this for a long time, and there's been some great co-produced reports about the contribution the voluntary and community sector make in health and care, which came out in 2018, was it? Which I was involved in, I think. And there's also the voluntary sector partnerships team within NHS England, which has been driving forward the VCSE alliances that are working with making sure there are voluntary sector alliances established aligned to each ICS, so that we can have some kind of opportunity for dialogue and co-production. And, you know, we're lucky to be part of an early cohort, but NAVCA are supporting other areas to develop those. And there's also guidance that's come out for ICSs, or a sort of self-assessment framework on how they are working with the voluntary and community sector. And we've done a RAG rating on that self-assessment framework, which has 12 points in it. And I have to say there was a lot of reds for our Northeast and North Cumbria area, but it gives us something to take to them to say, we can help you move from this red to an amber and then a green. But these, you know, let's co-produce the ways we can do that. So there is work going on, but it does feel that we're often having to push at a door that should be open and see us as an equal partner. Are there any questions in there, Kerrie, that we need to pick up?
Yeah, I think there's three broad themes that I've picked up on from questions and comments. So one was a bit of a pushback on this, Warren, your point that link workers are necessarily best hosted in the voluntary sector. There was a bit of discussion about the pros and cons of each and whether it's necessarily the case. There was another set of questions about what Jane's just said about how do we broadly demonstrate the impact and value of the voluntary sector offer and the role of infrastructure in supporting that, and a comment from, I think it was Mercer in Shropshire about libraries had made some had framed what they do as some very specific offers. And then the broader point, this is a $9 million question from Eva. How do new organisations or new services make themselves known to social prescribers and to PCNs, which again, I know a lot of organisations struggle with that and how they do that. And then there was this third theme around funding, a little bit about the potential role of personal budgets as an untapped resource from GITA, and also a bit of a discussion about free to access versus paid for. Is there a place for paid for services for people that can afford to pay for them as a funding stream? And Emily, I think in Norfolk, making the point that in some cases investment in the NHS social prescribing is meant in disinvestment in historic or previously existing roles of social prescribing. So I don't know if Warren or Alex, you want to pick up any or all of those themes, and if anybody wants to talk to their point or their question, maybe just stick their hand up and I'll keep an eye out.
Yeah, I mean, I've got thoughts. I'm sure Warren has too. I don't know whether you want me to go first, Warren, or...
I'm happy for you to go first, Alex.
Oh, okay. So I'll try to take a couple of those points, try and answer them all. So in reverse order, I think, how do new orgs get involved and get themselves known to social prescribers? Speak to your local infrastructure organisation. There will be one close to you. Look on NAVCA's website if you want to try and find out who it is. But as part of the points I made in my presentation is that the voluntary sector changes all the time. The landscape is totally changing constantly. We've seen lots of different things around how do we create directories of services, how do we make sure people know what's out there. It's almost impossible to keep that stuff up to date. But your local infrastructure organisation is generally the eyes and ears on the ground of what's happening in communities. They have development teams that are working with communities. They tend to have been involved in some way in new activity that's been set up. If they haven't, then speak to them. They will make sure that you get plugged in and made aware of in your local area to all of the key stakeholders and players that need to be aware of you, including link workers. That link leads me into the kind of question or challenge around where link workers fit and sit and should be hosted. And I recognise, I understand the debate, and I understand and agree with it doesn't matter, but it does matter. So I think we're talking less about sectors and less about is it the voluntary sector or is it the statutory sector that hosts the link workers, and more about, and actually Warren said the same on his slides, about links. So where they sit is rather important, so long as where they're linked into is really clear. And I've seen social prescribing link workers that sit within VCSEs, that sit within infrastructure bodies, that sit within PCSNs directly, and sit within housing providers and so on. But there's benefit, pros and cons to each of those. It depends what you're aiming for. So if you're a local housing provider, that's great. If your route is to link in with your communities in terms of your residents, because there will be a tendency to focus on your residents. Similarly, PCNs, that's great as long as they're linked into the sector. As Warren says, what we've seen time and again is PCN-based link workers then go out and map the voluntary sector because they don't know what's there. If they spoke to their local infrastructure organisation, they'd get much more knowledge about that and share that. But it's again, so it's about making those connections and make sure link workers are linked up. It's not predominantly about where they're hosted, I don't think. So having said that, we're currently working with NHS England, doing some analysis and a report on what the different kind of unique benefits are to where link workers sit. So we're doing some analysis of whether there are any wider findings about whether it does matter where they're sitting in VCSEs or in PCNs or others. So that report should be done towards the end of this calendar year, if not before. And I guess we'll make sure it's shared on Twitter and everywhere else, and look on our website too. And then finally on the costs, the costing issue. I mean, what I'd love to see in the future, Warren, just to make your life even harder, is if we could have that slide with the benefit side as well. So actually this is the ask, but this is what you'll get back, that return on investment type model. But the reality is that's impossible. And I think most of us would say, all of us would say we've been around long enough to know that you cannot quantify in the way we need to the value the voluntary sector provides to communities. But it comes back to the point I was trying to make about, and the question I was asking about, is there genuine strategic importance placed by all partners in a place on social prescribing? And that's a really challenging ask, because we're asking the local authority to think about what's the impact in terms of employment, what's the impact in terms of housing, what's the impact on public health, what's the impact on mental, physical health, and actually the costs of these challenges in the community is actually met by lots of different organisations. I would hope that integrated care brings us together in a way that thinks about it holistically, rather than to be a bit reductive about it. This is going to save my organisation X amount of pounds because there'll be less people taking up a hospital bed, or less people in social care, or less people in the criminal justice system. But that's what we're trying to establish, is how do you create those savings? It's across all organisations. So there is, I think, a reality that every organisation has got to recognise the benefits of this, and it's going to be very difficult to put a pound coin on it and say this is the actual saving.
And just before we go to Warren, Alex, there's a question about how small national charities might share what they do with social prescribers across England. Is there a route through NAVCA from doing that down through local infrastructure, or is that just because there isn't a national place where you can share what you do with all social prescribing link workers? Sadly, I can answer that part of the question, but is there a way around it?
Yeah, I mean, unfortunately, it's a really good question, and one we're actually discussing about small national charities' engagement in integrated care systems more broadly, not just social prescribing. I'm afraid I can't think of one. I think, unfortunately, I know this is really difficult and challenging for your capacity, but you may need to speak to each of the local infrastructure organisations across England to do that, to try and share what it is that you're doing.
I mean,
possibly-
the other way you could do it, sorry, is the Future Collaboration Platform, which is set up by NHS. It's not that easy to navigate, but if you can actually access that and actually register on that, then an awful lot of social prescribing link workers use that as a discussion forum and access information. So I would recommend that you do that.
And
I
I'd
was also
say,
wondering
Ron,
about NASP regional leads as well, Jane, whether we would be able to disseminate it downwards.
and that's
Yes,
To some degree. It's not perfect system, is it? But to some degree. I mean,
There's
with
also-
infrastructure organisations or with social prescribers directly.
I'm conscious we've got 5 minutes, so I'm going to give Warren an opportunity to respond to some of the questions because we are down to the last 5 minutes. How does time fly? Really good discussion, though.
It's really interesting that no one's batting an eye at the thought of investing 65 million into local grant pots, and and the issue that's controversial is whether it's a VCSE host organisation or not. So that's really interesting. For me, I think you're not always going to get a good host organisation in the VCSE sector, so it's not always possible. But I'd put in the need to think through some research into seeing whether it does make a difference or not as part of it. So I think that's key. I think the one thing I would point out around if you've got a good local infrastructure organisation is that there's 2 points here. And I do agree with whoever put it in the chat that the important thing is connections. And I think there's 2 things here, isn't there? There's one around connection, so knowing some people, and then there's connectivity, where that's slightly more strategic. So a local infrastructure organisation should be running a network of local voluntary sector organisations so that they can think about how they engage. And the really interesting thing around the Salford research was the impact the grant funding had because it could have the other services wrapped around it. So that includes thinking through quality assurance advice for local VCSE groups, thinking around funding advice. So if they want to build capacity, how they might go about getting investment that's not currently going to come from the NHS. And then thinking around how they might develop their services and their HR models. So that's all part of the package. So if you want an organisation that's going to host a link worker that then thinks through the quality and assurance system that groups are going through before they're referred to, so they'll have a track record of who's had grants in the past and who's delivered and who's not delivered. So you want to make sure you're getting people into organisations where you can't guarantee safeguarding, but you can guarantee a better outcome for the individuals that are going through there, and they'll care about that. That is one of their roles for infrastructure organisations, is making sure that the sector is of a substantial quality to pick at referrals. There's no way, I'm afraid, that a host of another organisation has the capacity to do that. The other thing to remember is that local infrastructure organisations are owned by their local sector. So the reason they're called councils is because they're a coming together of the local sector. They're an umbrella trade body, in another language, for the local sector. And that's why they bring an added level of connectivity and understanding of what's going on out there, who's delivering well, who needs more support, and who needs more investment. So that's why I think what we want to do is buy in a different kind of relationship with our host organisation that develops the sector such that we can feel safe, and the link worker doesn't have to do all the legwork on this. There's no way the link worker can fulfill their 6 remits that they have to, including the one about making sure the voluntary sector has capacity to do this. It's just not feasible. So I think it's connections and connectivity to the sector that those host organisations have. And that's why I've gone for that. But I think there needs to be proper evidence to make sure that my gut instincts are right. But yeah, but really appreciate the chat and all the feedback there today. So I hope you have a great day, everybody.
That's really great. Thank you. I'm just trying to answer something in the chat. Sorry, ambidextrous. I thought that was a really rich discussion. There's some really good points that have been put in the chat. Yes, the session is being recorded, so you will be able to access it, and you'll be able to access the slides. Alex and Warren, really rich information, really brilliant presentations, and I just wish we had longer really, but thank you very much to my co-chair, Kerrie, and thanks to Warren and Alex and for everybody participating. I hope you found it useful. Thank you.
And I have dropped this. I've turned the slides into PDFs and dropped them on a Google Drive while you've been talking. So
isn't she clever?
I've put the links in the chat because I don't know what happens to the slides afterwards, if I'm honest, but they're there if people want to take them away with them.
Okay, thanks very much.
Thank you, chairs. You were very
yes,
good.
if we could have a NAVCA conference to follow this up, please, Alex. Okay. Bye.